Well, good morning, everybody. It's nice to see you all here. Welcome to Grand Rounds. Today we have a special speaker, Dr. Jennifer Lyons, who is an ophthalmologist. She was trained at Indiana University for medical school. She did her internship at Legacy and her residency at OHSU. And she's been a great help for us in the residency program and for, I'm sure, many of you as well. She worked up until recently just right across the street here as our friendly neighborhood ophthalmologist. And she's going to give us a talk today on ophthalmology problems in primary care. Welcome, Dr. Lyons.
And now I'm further up the street in Gresham. Okay, I have no financial interest to disclose. So I think a lot of you think all we do all day long in ophthalmology is we say which is better, one or two, and we do a lot of that. And you probably aren't sending people over urgently for things like that, but I'm going to talk a lot about urgent things that you might want to know how to take care of and when to give us a call. So we're going to talk a little bit about red eyes. I'm going to, at the end, talk about exciting things with giant cell arteritis or temporal arteritis, and transient painless monocular vision loss or an eye stroke is how you should think about that. Things to be worried about when you see somebody with an eye problem, and think about calling us or referring to us. If they're having pain in the eye, it usually indicates a more serious problem such as iritis or angle closure glaucoma or infection. Decreased vision, especially if it's a recent or sudden change in vision. Look at the pupils. If there's a different size, we call that anisocoria, and also an afferent pupillary defect, which is a whole topic of its own that I'd love to talk to any of you about anytime. And then the pattern of redness. And so if it's more red, what we call a ciliary flush, near the limbus, so near the iris on the white of the eye, it usually indicates a more serious cause. Always try to check the vision. I know you guys probably don't all have a way to check the vision if you're hospitalists. There's no vision chart. If maybe in your office there isn't, but you can get these little handheld vision testers to check their near vision with. And if you're checking their near vision, make sure that you have them put on the glasses that they use for reading. So if they're nearsighted and they take off their glasses, have them take it off. And of course, check each eye separately. So even if the patient says they can't see anything, it doesn't mean that they can't see anything. So you still have to examine and check their vision yourself. So when you're thinking about red eyes, think about conjunctivitis, trauma or a foreign body, of course a chemical injury. They'll usually have a history of that to tell you. Iritis, which we also call anterior uveitis. Keratitis, especially with contact lenses, think of an ulcer. Angle closure glaucoma, a subconjunctival hemorrhage, and scleritis and episcleritis, which I'm not going to get into today. Okay, so here's some cases for you. This is somebody that comes in with a painful red eye. She's 60. She's got a pretty bad headache behind her eyes. She showed up in the emergency room with pain. She also had pretty bad headache, and she was vomiting. She was in distress. She's high blood pressure, she's on lisinopril, she's taking Tylenol and also a decongestant for some sinus problems. And she said she'd been having some headaches with nausea and vomiting sometimes and decreased vision lasting 3 to 12 hours for the past 6 months. And her primary care doctor said, oh, you've got migraines. This time it was a little worse, it lasted longer, so she went to the ER because it lasted for 8 hours. And she called it an 8 out of 10, and she was also vomiting. So what do you guys think this is? I'll show you again. Her pupils dilated. You guys are smart. But it could be an aneurysm. It could be a third nerve palsy. Her pupils dilated, right? Her eyes red. Well, in the ER, they decided to get an MRI and an MRA to look for an aneurysm. They didn't see one. But then she was really vomiting a lot, and so they decided to call GI. They did some labs. They were normal. Blood pressure was a little high. They did an abdominal CT. She was admitted. And because of her GI stuff, they for some reason did an exploratory lap. They didn't find anything wrong. And then the daughter the next day while she was in the ICU, she said, what about her eye? Her eye really hurts, it's red. And so her daughter really pushed to have them call me. And it wasn't at this hospital, just so you guys know. It was in town. So I checked her. They hadn't checked her vision yet. It was 2200. Her pupil was non-reactive, mid-dilated, as you could see. Her eye was red. Her cornea looked hazy. Her eye movements were intact, so it wasn't a third nerve. There we are again. So you guys called it. It could also be neovascular glaucoma. She's got high blood pressure that could cause blood vessels to grow in the iris, which could block the angle pretty quickly, so it could be that. And that would go along more if she said, well, a few weeks ago I started not seeing well, but that didn't happen with her. And so one thing to look at, if they're farsighted, their glasses magnify their face. And if they're nearsighted, their glasses make their face look smaller. I'll show you a picture of that. On the slit lamp or with your pen light, you can see the cornea looks hazy. And if you have a slit lamp, you can see that there's not much space between the cornea and the iris where the iris and sclera come together, where we call the limbus. And if you probably don't have a way to check the pressure unless you've got a tono pen in the ER, but if you just feel the eye and compare it to the other eye, it kind of feels firm. So you just have them close their eye and you kind of push on a little bit. It might feel firm. So here's a nearsighted person. You can see that her face looks smaller, looking through her glasses. And nearsighted people tend not to get angle closure glaucoma. But this guy, his glasses magnify his face, so he's at higher risk. And so one other thing to say, can you read without your glasses? If they can, they're probably nearsighted. So if they're nearsighted, they probably don't have angle closure. It's rare. If they've had cataract surgery, it wouldn't be common either to have angle closure glaucoma because taking out the cataract will take care of that problem. And I'll explain that to you in a second. And then you can say, well, what was that decongestant you're taking anyway? Oh, she was taking Benadryl. One way to check for the anterior chamber depth is to shine a light from the side of the eye. And if the angle is narrow, you can see that there's a shadow on one side. So on that top picture on the left, you can see that their angle is deep, and so the light goes evenly across the iris. And on the other one, because the iris comes forward, when you put a light on the side of the eye, it's kind of shadowed on the other side. So that's a good way to check for a narrow angle in your office. And so if you have a slit lamp, you can see this. There's that slit beam, and then you can see the iris. There's not much space between the slit on the cornea and the iris, so that's a narrow angle. And you always check near the limbus, near where the sclera and the cornea come together. And so this is just an idea to show you how the eye pressure drains out through the trabecular meshwork, where it says the fluid exits here. It's made in the ciliary body, which is that large structure at the bottom. Goes around the iris and then out through the trabecular meshwork, through the pupil. And so in an angle closure glaucoma, the fluid has nowhere to go. It can't get around the iris. It's kind of gets stuck, and then the iris keeps pushing forward, and the pressure goes up pretty quickly. We treat this with an iridotomy, which we can do with a laser, making a hole in the peripheral iris. We'll usually deepen the angle. So if you have angle closure glaucoma, it is an emergency. They can lose a lot of vision over hours. We treat it by trying to lower the pressure as much as we can with medication drops, especially pilocarpine, beta blockers, Diamox as orally. And we do the laser iridotomy as soon as the cornea is clear enough that we can get through it. And the other thing that really will help, and you might hear in your primary care offices about patients who are saying they're having cataract surgery because of their narrow angles, getting rid of the cataract just gives us more space. It lets the iris fall back, and that will treat the angle closure or prevent it if they're at risk for it. A lot of drugs can increase your risk of angle closure, as the ones that you can see here. Decongestants are a really common one. But some things to think about, sulfa medication can cause the ciliary body to become swollen, and that pushes the iris forward. And Topamax is another very common one that in a young person, in even a nearsighted person, can cause an angle closure. And stopping those medications can also stop the attack. So in this patient, her pressure was 60. I gave her a bunch of medications, got her pressure just down to 40. Got the iridotomy, but it was a little difficult to do to the corneal haze, but got it through. And her pressure went down to 16. Took her off her medications, it went up to 28. So now she's always on drops to keep her pressure down. Her vision did recover only to 20/50. And we did an iridotomy on the other side to prevent the angle closure on that side, and that side's good. Her pupil still is stuck in that kind of large state because after it stays like that for a while, it won't constrict with light, and she's got permanent visual field loss. This is her optic nerve. The cup of it's enlarged, and this is her visual field, which is pretty bad. So once the patient's had an iridotomy, you usually don't need to worry about what medications you prescribe. And definitely once they've had cataract surgery, you don't need to worry too much about an iridotomy. So all those risks you hear about when you're prescribing a medication. Don't take this if you have glaucoma. It's really don't take this if you have narrow angles and you haven't been treated for that with an iridotomy. So most people don't know they have a narrow angle. All right, this patient is a 40-year-old healthy teacher, came in scared because her eye was bleeding, aches a little bit, no history of trauma. She woke up with this. All of you know what this is. Very good. So painless red eye, normal vision, can happen at any age. Ask about trauma because this could happen if they were working out in the yard and they got something in their eye, so it's worth seeing them to check for that. And of course, if they're getting this a lot, you have to think about they could have a coagulopathy. You don't treat this with anything except for artificial tears, but don't use the ones that say they get the red out because it won't get the red out of this. Case 3, we got a 35-year-old gal. This happens a lot. Her 8-year-old had some pink eye. I want the same antibiotics that he got. And so she comes in with a right eye's red, it's watery, it's light sensitivity, very minimal discharge. Now her left eye's bothering her. This is what she looks like. So there's 3 main types of conjunctivitis. There's viral, allergic, bacterial, and there's fungal as well. Viral is the most common. It's very contagious. It's quickly bilateral. It's watery, sometimes a little bit of mucus discharge. They can have subconjunctival hemorrhages caused by adenovirus and enterovirus. They'll be photophobic, red, and they'll often have some other viral symptoms like a chest congestion or a cold. And the treatment is really just to keep everybody else from getting it. I tell them they're the hero if nobody else in their household gets it. Cool compresses, artificial tears. Antibiotics are overprescribed for this. They really don't help, but they're often prescribed, but not by us. And it lasts for 1 to 2 weeks. And it can be lingering irritation and light sensitivity for a few months if it's a bad viral conjunctivitis. And here's our next case. This one has more discharge. When you have that much discharge, think about bacterial. It's usually more unilateral. It's mucus and mattering. Think about MRSA lately. You can culture this with a swab. Not a bad idea to do that before you start any antibiotics. And it usually responds quickly to antibiotics. If it lasts longer, it's more likely to be viral. And fluoroquinolones we usually use for this. Ofloxacin is the generic that we often prescribe, but moxifloxacin and gadafloxacin are good as well. And if you think about MRSA, think about polytrim. That usually works best for MRSA. So allergic conjunctivitis, sometimes it's hard to tell it apart, but they usually are pretty itchy and they're watery. It's usually both eyes, unless they just happen to get pollen in one eye. And you treat this with over-the-counter allergy drops, ketotifen, which is called Zaditor or Alloy, or Patanol, which is olopatadine. Once or twice daily will help prevent this, and it also helps treat it. Okay, case 4, we got a 55-year-old man. He's got an irritated red eye for 3 days. His eyes are crusty. He's watery. Maybe he's got some mucus. Only one eye's affected. Kind of sounds like a conjunctivitis, right? Here he is. So what do you want to do? Do you guys want to prescribe an antibiotic? Or do you want to do one with a steroid like Tobradex or Maxitrol? I see a lot of that come into my office from outside because it helps with the inflammation, right? But if you got some fluorescein, I want you guys to remember that don't always think about a steroid. So in this cartoon, I want you to come back here in 2 weeks and just say no to pest strips. And I'm going to say, just say no to steroids, unless you have a slit lamp and fluorescein. Because this is what this guy had when you put fluorescein on him. You guys all know what that is. It's pretty classic. We call this a dendrite. That's classic for HSV. If you treat it with a steroid, you might get a perforation on the cornea. So that dark spot down on the lower part there, that's a perforation. That's where the iris came through from somebody treated with steroid eye drops for a herpetic conjunctivitis. So this little spot right here is where the iris perforated through. So you see the dendrite that I showed you earlier. Oral antiviral, such as acyclovir, works well for this, or Valtrex. Topical Viroptic is one that we use. It's used frequently. May not be as beneficial as the oral, and definitely don't use steroids. If you use steroids with a dendrite, it's going to get worse, and you can get that perforation. You can get a corneal perforation, melts. It worsens the HSV dendritic keratitis. You may see us prescribing steroids when it is not affecting the epithelium, so for more chronic herpetic keratitis, we'll use it, but only very carefully and watched by us. Steroids can also worsen a fungal keratitis, and it will increase your intraocular pressure in a good number of people if it's used for a long period of time. So unless you have a slit lamp and you can check the pressure, don't do it for anything. You got to be really careful watching people on steroid drops. So here's somebody who had a perforation from a fungal keratitis that was treated with steroids, and now they just have a opaque cornea and vascularized, and there's not a whole lot we can do with that. Cornea transplant often does not work well in this. Okay, case 5, we got a 40-year-old man with pain in his left eye for 2 days. He was working on a car a couple days ago, and his eye started hurting that night, and his vision's pretty good. You guys see what's wrong there? That little guy right there. Sometimes they're kind of hard to see, especially if they got brown eyes. It's kind of hard to see. So this can happen to anybody. A lot of times I see it when somebody's just walking to work and something blew into their eye, and it can be metal. But it's more common with their grinding on metal. Even if they got their protective glasses on, it gets into their hair and their eyebrows, and it falls into their eye later that night. And you just have to remove that with a needle, or what we call a spud, which is kind of like a needle at the slit lamp. And here's somebody who has similar symptoms, but you give them fluorescein, you see these kind of lines on their cornea that stain. Sometimes people don't recall their injury. We treat the abrasion with antibiotic drops just to prevent infection, or an ointment and a pressure patch will make them feel comfortable. We often put a bandage contact lens in the eye, which is just a regular contact lens that we just leave in until it heals, and that gives them a lot more relief than a pressure patch. And so if you can get them in to see us, that usually makes them more comfortable, and then they keep their binocular vision. We have to watch them very closely with the bandage contact lens because that can increase risk of infection too. Always make sure to look for a retained foreign body, and follow them every day if it's large, and every couple days otherwise. And if it's larger in the center, you probably should send them to an ophthalmologist. So the picture I showed you with the little lines on the cornea, flip their lid, and you guys see this little thing here. So you got to get that thing out, otherwise their abrasion's not going to heal. So you're the hero if you take that thing out. You just give them an anesthetic drop. And if you don't have proparacaine in your office, you can just use some lidocaine that you drop for other things. Just put a drop of that on the eye. And it's really easy to remove this with just take a cotton swab, flip it around, use the wooden end of the cotton swab, and that usually just flicks it right out. All right, case number 6, this is a 50-year-old carpenter. He was helping out at the job site, pulling out some floorboards in the house, and he felt something hit his eye. It started watering, so he thought, I got something in my eye, so he's trying to take it out. But the thing that he was trying to take out was his iris. His vision's pretty good. They sent him in to see me from Seaside. So you look for a peaked pupil, and you just think about with a ruptured globe what the mechanism of injury was. If they've got hit really hard or something hit their eye pretty fast, you got to really think about a ruptured globe. Don't check the eye pressure if you think they have a ruptured globe. You don't want to really touch it in any way. Put an eye shield on. If you don't have an eye shield in your office, you can just cut off the bottom of a paper cup and just kind of tape that over their eye so they can't rub their eye, because they really do want to rub their eye as much as you try to tell them not to. Tell them to stay NPO because we're going to have to do surgery, and send them to us right away. You don't necessarily want to send them to the hospital always because they often have to send them somewhere else. All right, case 7, this person's 45-year-old man. He's got a red eye. He's pretty sensitive to light. His eye's really red. He's got some arthritis in his back, but he's otherwise healthy. His vision's 20/30. Anybody want to take a stab at what this might be? Oh, you guys are good. Anterior uveitis, or iritis, was the correct answer. You guys are getting them all right. You don't need me. So they're usually red. They have a lot of light sensitivity. Especially if it's acute. It can be subacute. There's also chronic iritis, which can be more silent and just general mild redness. But the ones you'll see that come in quickly, it's often associated with HLA-B27, but it can be seen with any autoimmune disorder or connective tissue disorder. Sarcoid is common. Inflammatory bowel disease, about 2% of people with inflammatory bowel disease get an iritis. You treat this with dilating drops to help with pain. Because they kind of get I like to say, a muscle spasm in their iris, and that's what causes their light sensitivity. So when we treat them with a dilating drop, it takes away a lot of their pain. It also helps prevent and treat posterior synechiae, which I'm going to show you a photo of. And we also treat them with prednisolone drops. And you should always refer these. They can have other things too. They can have herpetic keratitis or infections, which of course you don't treat with steroids. You guys see all those little white spots in the cornea? You can see those with your pen light probably. You guys know what those are called? We call them keratic precipitates. It's kind of cells that are stuck on the endothelium or on the back of the cornea, frequently seen in sarcoidosis. Posterior synechii is the iris that kind of sticks to the lens, and they'll have an irregular pupil. So here's somebody with posterior synechii. So we dilate them, and they just don't dilate up normally because they have all these little spots on the edge of their iris which is stuck down to the lens right below. And putting them on the dilating drops will help prevent that. Okay, here's another case. This 25-year-old nurse. She's got painful red eye for a day. She wears soft contact lenses. She sometimes falls asleep in them because she works late, but she usually takes them out at night. Her vision's pretty good. She's 20/30. And you can see this white spot on her eye right there. It's just kind of red, mostly down below. That white spot may or may not stain with fluorescein. You guys know what this is called? What's that? Here's another one, a bigger one. So we call these a corneal ulcer. The infiltrate is the white spot on the cornea, so that's a corneal infiltrate. The ulcer is the infiltrate that stains, which is more serious. It's most commonly seen in contact lens wearers, especially people who wear their contact lenses overnight or extended wear. And contact lenses are prescribed that way, but we usually tell people don't do that. You should take them out every night and clean them because the risk of a corneal ulcer is much greater if you don't take out your contacts and clean them every night. It can be seen after corneal abrasion. That's why you follow abrasions carefully. When you get an abrasion, any bacteria can be on whatever caused the abrasion, and so that's why we watch those carefully. And also seen in blepharitis and rosacea. So the treatment is to stop the contact lens. Tell them not to throw away their contact lens. If we can't get a positive culture, if they're not responding to treatment, we can send that contact lens ulcer in for to the lab to see what bacteria is on the contact lens. So tell them to keep it until we're sure what's causing it, but don't use it ever again. Same thing with their case and their contact lens bottle that they're using. Once they're all cleared up, you throw everything away and you start fresh. We usually treat this with a fluoroquinolone drop, but we treat them pretty hard with every 15 minutes. And that's something you guys can all do. Just go ahead and start them on the ofloxacin or the moxifloxacin or the gadifloxacin. And we don't treat it lightly. We treat them every 15 minutes for 4 hours, and then every 30 minutes for 4 hours, and then every hour, including through the night. When it's big like this, you make them get up at night. And if it's not responding to the fluoroquinolone, then we'll put them on stronger antibiotic drops that we usually have compounded. They should follow up within 24 hours to an ophthalmology, especially if it's in the visual axis. And don't try to get a culture on this. We have to scrape it with a special little spatula to get a good culture result. So it's really not worth your while to try to get a culture from these. People with corneal ulcers can lose vision. They can get endophthalmitis. The infection can get into the eye. They can have a perforation of their cornea, and they may never be able to wear their contact lens again. I'm mostly talking about bacterial corneal ulcers or keratitis here, but fungal keratitis is really bad, and they're the ones that can really perforate. And that's one of the reasons why you have to be very careful with ever using steroids for something like this. As they're healing, we will often add steroids as ophthalmologists, but we don't usually start them with steroids. Sometimes it's hard to distinguish this from contact lens overuse or keratitis caused by kind of an allergic reaction to their contact lens solution. Usually with them, there's several white spots in the cornea, not just the one. And also if it's contact lens overuse or keratitis caused by their solution or the material of the contact lens that they're using, that's usually bilateral, not unilateral. That's my husky. So we're going to change from red eyes here and go on to a couple really exciting things. So case number 9, we got an 80-year-old recent widow. She's got high blood pressure, which is well controlled. She's got breast cancer in remission. She saw her internist for fatigue in October, and she's getting weaker. Her appetite wasn't as good since her husband died last year. She's lost 15 pounds, and she wasn't overweight to begin with. Her CBC showed some mild anemia. Her ferritin was low, so a consult was set up with a GI, and she hasn't had a colonoscopy in 20 years. And she couldn't get into the GI doctor for a couple of months, so she's kind of waiting for that. Her cholesterol was a little high, so they put her on Lipitor. And because of her loss of her husband, they diagnosed her with anxiety and depression and put her on an antidepressant. So that was in October. She came back in November. She saw the PA at the internist's office. She was having some headaches, and her muscles were aching. And the PA said, well, maybe your aching muscles are the Lipitor, so they decreased the dosage. She went to the ER a couple weeks later, and she's having some fatigue. It's getting worse. She's having more headaches. She said her right eye was blurry. It seems gray sometimes. And this is all in the ER notes. There's no eye pain, but the headache is kind of behind her eye and above her ear. So they did a head CT. They also did a urinalysis because of her fatigue, and they put her on an antibiotic for a UTI that she had. And she said they told her to go see her eye doctor for the vision blur, but it's not urgent. 2 days later, she can't see anything with her right eye. She calls her ophthalmologist up, gets in the same day. Her vision is hand motions. So when we're checking vision and they can't see the E on the chart, the next step we say, can you see how many fingers I have? And we check at different distances. So we'll say counting fingers at 3 feet, 2 feet, or 1 foot. If they can't do that, then we check for motion. Can you see hand motion? If they can't see that, then we call it light perception if they can see light. And if they can see nothing, it's no light perception. So this patient was hand motions in her right eye. The left eye was good at 20/30. Her pressure was normal. She's pseudophakia. She's got an afferent pupillary defect. Her left eye started to seem blurry around at that time, just kind of like the right eye was before it lost its vision. And the ophthalmologist asks a little bit further, and has your jaw and tongue been hurting when you eat? Does your scalp hurt when you touch it or comb your hair? Yep. And before she came into the ophthalmologist's office, and just a few months ago, she was walking 3 miles a day, and now she can barely walk in the office without stopping every 15 feet or so. So the ophthalmologist said, you really just seem like you're really getting fatigued. And she said, yeah, that's what I've been telling my internist. They say it's depression. So here's on her exam. You can see her optic nerve here. You can barely see the edge of the nerve is kind of blurred. It's very pale. It's white, and it's swollen. So we'll call that an ischemic optic neuropathy. And when it's pale like that, that usually means that it's arteritic. So the ophthalmologist sends the patient to the ER and calls the ER ahead of time and says, you need to start some IV steroids on this patient as soon as they walk in the door. Before you get any labs, just put them on IV Solumedrol. They did check a SED rate of 65. Her C-reactive protein was 3.8. The ER said, well, let's just put you on oral prednisone. Let's just give you 60 a day. And the patient was sent home with instructions to follow up with the internist and a vascular surgeon for temporal artery biopsy. They didn't give any IV steroids. They didn't call the ophthalmologist back. And the patient went along with that plan. And the patient loses vision in the left eye, their good eye, the next day. Their hand motion in that eye, too. The temporal artery biopsy was done 10 days later, and it was positive. The vision got to bare light perception in the right eye, and the left eye has not improved from the hand motions. Prior to this, she was living on her own at home. She was driving. She was active in her church, and she's now in assisted living because she can't see. She had symptoms that she mentioned to her internist and that first ER doctor many weeks before she lost her vision. Neither of them asked pointed questions about scalp tenderness or jaw or tongue claudication or detailed vision questions, or at least it wasn't in the record. All of those things going back, she said were positive, but nobody asked. And there was a big lawsuit against the internist. So is the ER doctor liable? The first one, the second one, or both? Doesn't matter. It shouldn't have happened in the first place, right? So giant cell arteritis is temporal arteritis. It's more common in Caucasian females. The female-to-male ratio is 3 to 1. The incidence is 30 out of 100,000. The median age is 72. We don't know what causes it. So the symptoms are a new onset headache, dull or achy, 60 to 90% of people. Everybody with a headache who's older than 60, you should think about giant cell arteritis. Ask them these next questions. So scalp tenderness, which can be on the temporal, usually above the ear, or in their occiput, 40 to 70% of people will have that. They'll have polymyalgia rheumatica with the achy shoulders and hips. That's about 50% of people. The jaw and tongue claudication are 30 to 50% of people. So the question to ask, does your jaw or tongue muscle hurt when you're eating? A lot of people say, yeah, it hurts in my jaw joint. No, not there, in the muscle here. They often can't eat for long because it starts hurting when they're eating. Their tongue gets sore. They get weight loss and fatigue and anorexia, happens in 20 to 50% of people. Transient vision loss before they lose their vision happens in 20% of people. So their vision kind of blurs in and out, or it goes in and out. And that can happen for months before they are diagnosed with the giant cell, but sometimes just a few days. Double vision can happen in 10% of people. Permanent vision loss happens in 15%, and as in this lady, you can see it can become bilateral within days. So have a high level of suspicion for this, for all patients over 50, for transient vision loss or double vision. It's pretty rare to see this in somebody who's less than 65. So you get a stat sed rate and a C-reactive protein. If they haven't had any vision loss, get the sed rate and C-reactive protein first. It's sed rates more than 50 in 90% of people with giant cell. So a normal for a male is their age divided by 2. And for females, it's their age plus 10 divided by 2. The sed rate's more than 160% of people, and the C-reactive protein is 2 times normal in more than 90%. 30% are anemic, and an elevated platelet count you'll see in 30%, so we always get a CBC with them. And don't wait for the results if you're suspicious. Just go ahead and start the prednisone now. And use IV steroids if there's any vision loss, even if it's transient, or if they have double vision. Otherwise, you can start them on prednisone. And don't be wimpy about it. Start them on a high dose. They hate it, and there's all these side effects you guys see them for that are problematic with their diabetes and such, but you got to start them hard on this. So 80 to 100 milligrams is a normal starting dose. So the rule of thirds in giant cell, a third will lose their vision permanently. 2/3 will have had symptoms for at least a week before they lost their vision. Of the patients with the vision loss, which starts as transient, a third will go blind within a day if it's left untreated. A third are blind within a week, and all the rest are blind within a month if it's left untreated. So the cause is that ischemic optic neuropathy, and also central retinal artery occlusion can cause vision loss. So once again, here's a ischemic optic neuropathy. The optic nerve is pale and it's swollen. So start your steroids first, shoot first, and ask questions later. Biopsy them within a week. The biopsy will remain positive for at least that long after the steroids are started. So don't wait on your vascular surgeon to do the biopsy. Try to get them in for a biopsy as quickly as you can, but don't wait on the steroids. Also, don't wait for the patient to come see us. If you think they have it, then go ahead and start them on the treatment and get them in with us. Give us a call. And don't wait for your rheumatology consult either. You may not get them in quickly enough, and you guys can all diagnose this too. 10% of people with temporal arteritis do have a negative biopsy. You need to have a pretty good section of it. So it needs to be a 2.5 centimeter section, and they have to look at multiple areas within the biopsy, and the pathologists are usually good about doing that. The treatment, you put them on the IV steroids, 1 to 3 grams a day for 3 days. And then you follow that with a high dose of prednisone and a very slow taper. A lot of mistakes I'm seeing with the temporal arteritis coming back is with too fast of a taper because the patients are complaining about their side effects. You can consider, of course, starting with oral prednisone if there's no vision loss and there's less symptoms. Less than 5% regain their vision if the steroids are started within 48 hours. But starting the steroids right away if they've lost vision in one eye will dramatically reduce their risk of vision loss to the other eye. Actemra is now a treatment to be considered in the place of the steroids, but you still start with the prednisone. It's an interleukin-6 receptor alpha inhibitor. The rheumatologist will start them on this. It's given subcutaneously every week with a 26-week prednisone taper. Methotrexate and Imuran have had mixed results. So very slow taper once again. If they have any vision symptoms, you have to really taper them slowly. And then you keep them at a pretty high dose, 40 to 60, once they're asymptomatic, and you taper them slowly over 1 to 2 years, following their sed rate and their symptoms. And you taper them every 2 to 4 weeks, checking their labs and asking them questions each time. So don't wait for us. Once again, don't wait for neurology. Test now. Don't wait for rheumatology. Okay, here's my bike. I'm going to tell you guys a fun story. This is my bike. I've been riding the Max because I live in Southwest Portland and I work out in Gresham, so I ride the Max some days. I had my bike hanging up in Max, and at a really busy stop, people were pushing around. Guy took my bike. The bike's gone. The cops said, well, we'll look into this in a couple weeks. There's more important stuff going on. I went back the other way, and I got on a Nike bike, looked around, got in an Uber car, looked around. But they said, well, if you see it, don't engage with the person because we want you to stay the victim and not the suspect. So it's the same, as them saying, well, we'll get to see this in a couple weeks. We can't get in to see them. But maybe you shouldn't always follow that advice or you'll get burned. And your patient will lose vision if you wait for them to come see us. So maybe you should look for that bike. I wasn't really looking for it. It's Portland, never gonna find my bike. But I happened to be riding my other bike home a different way. It just kind of felt like going a different way one day. I ran into this guy. Look, it's my bike. I found my bike. I was so excited. That is my bicycle. He still had my computer on the bike. That little thing right here, that's something like 1999. You can't find this anymore. He still had that on there. He had a broken spoke. He put all this tape across the top so you couldn't see what kind of bike it was. He let me take his picture. He's a really nice guy. I made him the hero. I said, you found my bike. And he said, I figured somebody was missing it. And he gave it back to me. I got my bike back. All right. So I'm going to tell you about acute retinal ischemia. So transient monocular vision loss, or branch retinal artery occlusion or central retinal artery occlusion. That falls under the category of acute retinal ischemia. So here's a patient who's got a branch artery occlusion. You can see the whiteness here, all this white here. They'll only look like this for a short time, and then the rest of the vessels just kind of get pale, and the retina looks pretty normal after a month or so. Except that little white spot will stay there in the vessel. Here's a central retinal artery occlusion. There's the classic cherry red spot that we talk about. It's not really red, it's just everything else is white, so it makes it look red. That one's circled. You can see the little Hollenhorst plaque, and then the whiteness in the retina further from there. So sudden painless loss of vision. Always think about temporal arteritis. Check their SED rate and C-reactive protein. Always think of temporal arteritis. This is a stroke in the eye. We don't work this up as an outpatient. This is a stroke. You send them to the emergency room. As soon as you can, they get into the ER. This is a TIA of the eye. You treat it and work it up the same as any other TIA. This is an infarct. It's the same as a stroke. 10 to 30% of patients with transient monocular vision loss will have a silent acute cerebral infarct on diffusion-weighted MRI. Up to 75% of central retinal artery occlusions have an infarct that is seen on an MRI. 25% of the TIA patients have a treatable etiology, and so you can prevent a major stroke. They may have AFib or greater than 50% carotid stenosis. So going back to that, I think a lot of times with the acute retinal ischemia, you say, well, you've lost your vision's kind of going in and out, going to see your ophthalmologist. Really, if there's a sudden change in their vision they can't see, or you see something like that, that should be considered urgent. If it's been going on for several weeks, maybe they can see us, but otherwise work them up quickly. So send them into the stroke center, tell them it's a stroke in the eye, and you can prevent them from having a more major stroke later on. So we got time for questions. Anybody have any questions? Yes?
Well, we're having our epidemic of syphilis. Do you have any advice about early detection of retrobulbar neuritis and other complications of syphilis?
Yeah, okay, so syphilis can cause a lot of ophthalmology complications. Uveitis is pretty common with syphilis, and they can get an optic neuritis as well. It is, as you know, very difficult to diagnose. So you do your blood workup for it, and if they have ocular syphilis, you treat it as tertiary syphilis. And send them to that guy. Yes?
One of the most common occupational hazards is foreign bodies in the eye. Just say a few words about traumatic eye problems.
So he's asking about foreign bodies in the eye and traumatic eye problems. Wear your safety glasses. That's key.
In terms of redness and pain and how you work those up.
Right, so flip the lid and look for something underneath the eyelid if they have a corneal abrasion. And you treat the abrasion as an abrasion, so with antibiotic drops or a pressure patch over the eye. If you think they have a ruptured globe, they have to come in to see us. Does that answer your question? There's a lot more with trauma.
I'm just curious if you see a lot of redness associated with trauma or whether that's not.
You usually see redness with trauma. But if it's a small foreign body, sometimes they're not that red, especially if they've been putting some vasoconstricting drops in their eye. Yes?
On that same line, you mentioned using a needle to remove a foreign body. What are you just
Okay.
taking the tip of the needle and
So yes,
flick it off? Or
we do. So when they're at the slit lamp, there's a little instrument we call it a spud, and it's kind of a blunted needle, and it's probably about a 25 gauge size, and it's a really nice way to pick the foreign body out of the cornea when it's stuck in there, when it's a metallic foreign body. I wouldn't recommend doing that without a slit lamp, however. If it's a foreign body underneath the eyelid, take the wooden end of a cotton swab, and that's a really safe way to get the foreign body out, and it works most of the time. Yes?
Great talk. A couple things. Could you explain the corneal swelling with acute narrow angle glaucoma crisis? What are drusen? And could you talk a little bit about the occupational hazards of farm workers and that kind of thing in terms of their eyes?
Okay, so he's got 3 separate questions. One is corneal edema or swelling with angle closure glaucoma. So if the pressure suddenly rises, the cornea gets swollen, so it just looks hazy.
Is there a mechanism?
The cornea can't clear itself. You clear the cornea from the endothelium, the inner side of the cornea, so if the pressure's up, the cornea cannot clear itself. So any sudden increase in pressure is going to cause the cornea to swell. We do see corneal swelling for a lot of other problems. Basically, a lot of the infections or ulcers you see corneal swelling with also, and corneal dystrophies, that you get gradual swelling of the cornea as well. Your second question are, what are drusen? That's a big topic. Okay, so drusen are, you can have optic nerve drusen, which are congenital, which can cause crowding of the optic nerve and visual field loss, which can be significant. And they're just little white spots that you can see on the optic nerve. And you don't always see them. Sometimes they're buried, and so we can only pick them up. Sometimes you can see them on autofluorescent photographs. We can sometimes see them on CT scans as well. Drusen in the retina. So macular drusen, when little yellow spots that you see in the macula. And when you have a lot of macular drusen, that goes along with macular degeneration. And so they're deposits that you get in the retina. And it's hard to find an 80-year-old who doesn't have any drusen. A lot of people have a few, but when you have a lot of them, it's macular degeneration. And your third question was about farm workers and their occupational hazards.
Eye hazards.
There's all sorts of stuff that the farm workers can get. A lot of times they're
Sun exposure.
Oh, sun exposure. Well, okay. Well, the sun can cause a lot of problems: macular degeneration, cataracts, pterygium, which is a growth on the surface of the eye, frequently seen in people who've spent a lot of time in the sun. So wearing sunglasses is a very good idea to do. Even up here in Oregon, people get a lot of problems related to the sun from not wearing their sunglasses. And a hat is a good idea for all farm workers as well. Farm workers also have a lot of injuries that they get in their eye because things are flying all over the place. Landscapers have a lot of problems. I've seen so many eye traumas from people with leaf blowers or lawn mowers. Wraparound glasses are very important, not just regular glasses, to prevent something ricocheting off of a retaining wall and coming back at them. Whenever I see somebody with a leaf blower, I cover my eye when I'm walking by them, even if I have my glasses on, go to the other side of the street. I see a lot of foreign bodies and people who had nothing to do with the person that was doing the work.
Can you reverse I forget what you call it, those little spots on the cornea?
The spots on the cornea?
Yeah.
The pterygium?
Yeah.
Pterygium you can't reverse. When they get inflamed, we treat them with steroid drops. While they're inflamed, that's when they grow. The only way to get rid of a pterygium is with surgery. Yes?
Do you have any tips on everting the upper eyelid? I've always found it a little bit difficult, and the patients kind of blink.
Yes. Okay, so tips on everting an eyelid. Have the patient look down, and you grab a cotton swab. So you take the cotton swab and you put it in the crease of their lid as they're looking down. You try to grab their eyelashes. If they don't have any eyelashes, it's really hard to do. But you try to grab their eyelashes or the outer part of their upper lid near where the lashes are. And if you grab more temporally than nasally, you usually have more success. Have them continue to look down. If they're continuing to look down, then you put their cotton swab there and you flip the lid as you pull the lashes. Yes.
Another question, have you seen more information about the herpes zoster virus being involved in temporal arteritis?
Yeah, the herpes zoster, there's a question of whether or not there can be some issue with the shingles causing a temporal arteritis. Because we really don't know what causes the majority of temporal arteritis. Shingles can cause all sorts of other things too. You can get cranial nerve palsies with it as well. And there's cranial nerve palsies you get with shingles, so there may be a connection there. Yes?
I thought one way to differentiate iritis from other forms of red eye was limbic redness, but your photograph didn't seem to display that.
That's correct. So classically, if they have iritis, if it's not too severe, the majority of the ciliary flush will be closer to the limbus. But that's classic, but that's not what we always see. So often they have their whole eye is red. I just saw a patient last week referred from the ER for, she definitely doesn't have any cells in the anterior chamber. I'm certain of that. Her whole eye is red. And she had just really bad iritis. So if it's significant iritis, she had 3 to 4 plus cells. The whole eye is red. If it's mild, if it's just trace the 1 plus cell, then you'll get that ciliary flush. But if they're really symptomatic and they have significant iritis, the whole eye is red. You guys have good questions. Anything else?
Thank you
Thank you.
very much.